everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you another in our series of interviews with top leaders in healthcare IT. Today's guest is one I've interviewed over, I think, a decade of time. We've had a lot of different interviews. A longtime friend, one of my favorite people to interview because he's got incredible insights. But today he has a special announcement of a new company, and that's Alan Portela. He's CEO of his new company, Adjuvare, and he's also still CEO of Airstrip. Welcome, Alan.
Thank you. Thank you for having me. And it's always a pleasure being in your program. And if I remember, the last time I was on your program was in 2017.
Wow.
And we were talking about interoperability, how important it was going to be the role of the government with interoperability, reimbursement, and here we are. It had to be COVID, not the government, that changed everything.
It definitely forced a lot of things, didn't it?
Yes.
Well, and it's quite interesting. You know, I've obviously known you at Airstrip as the CEO there for a long time, and this new company is kind of an outburst of Airstrip, I would say. An extension of what you're doing, an acceleration. But before we get there, for people that don't know you, tell us a little bit about yourself and about your previous company, Airstrip.
Well, thank you. And of course, as you know, I will still be running Airstrip, so it's not the previous company.
Yeah, that's fair.
I would say it's the foundational pillar of what we're doing here. So definitely, you're right. It's been a decade since you and I have been communicating. And the good news is that we have not been behind the scenes doing things. We have been leading the industry together, you with what you do and us doing what we do at Airstrip, and a number of other game changers are there with the incredible help from our provider customers. So about myself, well, I have been the CEO at Airstrip for the last 11 years. It's going to be actually in January of 22. It's going to be 11 years.
Wow.
I have been in healthcare technology since 1993, so for a long time, and always in the area of high acuity, hospital high acuity on technology, been working with technology always in ICU documentation, virtualization, and communication tools. So definitely, I will say that many times I feel that I was ahead of our times with the things that we were trying to do. As you can imagine, I was doing mobility probably in the early 2000s when mobility was just at the early stages. We were doing command and control dashboards back then when it was too early. And then, of course, the whole concept of virtual acute care, when everybody was concentrating on telehealth for primary care. So I think this is where everything converges. So I'm so excited about this moment.
Yeah, so obviously you've had some great success at Airstrip. I mean, created a great company with hundreds of hospitals using your product, but now you're launching a new company called Adjuvare. What's the thinking and the vision behind this new company?
Thank you. First, I will tell you about how we got to what we're doing at Airstrip and how it becomes the foundation of this. Because I would say when I started at Airstrip about 11 years ago, we knew that we had to be disruptive, and we created very good methodologies on how to innovate. And basically what we did at Airstrip is we put 45% of our resources and funding levels, everything about core technology and core customers. 40% on adjacent technology and adjacent markets, and 15% on transformational technology and transformational markets. So if you do things right, after a period of time, most of your revenues will come today. 45% from what used to be 15% transformational now becomes your core. And whatever was your core becomes 15% of your revenue. So if you're very disciplined about how you look at things and you have the right vision, then you succeed. Now, I cannot claim that it was my vision, it was my customers. That we were very close to them. I was not an EHR company or a medical device company that basically you can go out there and think you can tell the customers what they need. Being a startup, I had to listen to our customers. And I was very fortunate that as they started evolving in the concept of what they needed on virtual acute care, they definitely came to us first with the issue of interoperability. There were gaps on data gaps inside the hospital that they were very pronounced. The shortages at the time, they were just, if I'm talking about a decade ago, it was in the ICU. It was always known since 1999, the Leapfrog report, if you recall, ICU staffing shortage. This was identified by Leapfrog in 1999. So you can actually go on and research that. And so the staffing issue was always there, but of course, now it propagated throughout the entire enterprise in healthcare. So as we evolve, I will always think that when you're ahead in the industry, ahead of your times, you're always going to be confronted with the fact that people are going to see you as very cool technology and a nice to have. The key issue for any company is how do you go from nice to have to a must have? And you constantly look at how does this technology impact the clinical workflow in a high acuity area, specifically in the emergency department, ICU, telemetry. And we always looked at all those clinical workflows. And I would say pre-COVID, we were probably installed in about maybe 300 hospitals. And in every hospital, we had our platform. I remember your article about platforms, analytics, and communication tools. So we had our platforms deployed, and we had some communication tools, the applications to show the waveforms, as you know, from the monitors, some secure messaging and other things. But COVID, the moment it hit our customers in New York, this is in March 2020, it was one of our customers in New York, Memorial Sloan Kettering, that already had our platform and our communication tools. And they said, we need to apply the tier staffing strategy from the Society for Critical Care Medicine. Those guidelines were updated in March 25th of 2020. And in essence, it was one ICU expert supporting 4 teams of 24 patients each, 96 patients per ICU expert. And they said, if we can have the ICU experts from any location looking at a command and control dashboard, using the communication tools, as you described in your article, but start applying some AI for intelligence surveillance, this is the way we're going to be able to deal with this. And I was so fortunate, John, and I will come to the answer on Adjuvare in 2 seconds. I was so fortunate because they taught us how technology could be used to bring clinical staff augmentation, clinical staff collaboration, and clinical staff protection. How can I keep those that are the experts being away from being exposed, but also what happens to those clinicians that were exposed, potentially tested positive, but they're still feeling okay and they can help remotely now.
Yeah, that's great.
But also we had volunteers that came from other states before COVID was in everywhere else. And we will get calls from other customers in New York that said, can you configure 1,200 beds and 400 physicians and nurses and extenders in 72 hours? And you would think, how the hell can you do that? Well, if you have the platform, you have the medical devices in place, connected to gateways, and my platform was already there. I just had to turn on and configure users. So we were actually able to do that. We learned a lot about ourselves because my team didn't sleep for days to be able to support our customers there and help others throughout the country as the pandemic expanded. So now the lesson from my customers was, after the first battles were fought, they came to us and they said, well, it is clear to us that now the biggest issues that we found that were exposed by COVID were related to data gaps and staffing shortages. So they came to us and they said, we need to start figuring out, how do we open up more vendors? The thing that you and I were talking in 2017 is just that now when the hospitals went to the vendors to open up, they couldn't block. They couldn't block the data because we're all in a worldwide pandemic.
Yeah.
If you block the data, then now you're a monster. You're really bad.
Sure.
So COVID, behind the scenes, people didn't realize this, but it opened up. Every vendor was willing to open up and share their data. And this was a huge issue for us because we started now being able to leverage our technology to support the hospitals, but also now we started looking at staffing. How can we apply the models of one-to-many for staff augmentation inside the hospital? So I always knew, John, I started reading where COVID was going, and I always knew that for the first 12, 18 months, the issue was going to be about hospital acute care, but eventually it was going to be moving outside of the four walls of the hospital. Mm-hmm. Because we always had an issue of chronic patients, but now we're bringing long haulers into the system. And now we have less doctors and nurses to take care of patients. So everything gets more aggravated. Mm-hmm. So as we are now applying technology for staff augmentation, the customers came to us and they said, can you start looking at how we can move this level of care from the hospital, acute care, outside of the four walls of the hospital? What is the technology that we need? But how are we going to fix the data gaps that we have today still, and the staffing issues that we experience today that are only going to get worse when you're trying to go and monitor every patient at home with that level of care? So we started evaluating what the best approach was. And we looked at all the telehealth companies out there that put a lot of emphasis on wellness, prevention, primary care. There is a lot of that. But then we recognized that the fastest areas for growth in the market are post-acute care transition and acute care at home. The reimbursement is there, but the staffing is not there. So we started thinking about that this was probably the time where I always looked at Airstrip as, we were always a technology company. If you look at our assets, it was a technology, it was the strategic customers that we have, and then, of course, us, the people that made it possible. Mm-hmm. COVID took us from 300 hospitals deployed to 470 hospitals. But on every hospital, we deployed our system throughout the entire institution. This hospital alone, we added 130 hospitals that are not deployed. We signed the contracts, and now we're moving forward with those deployments. So definitely at this level, where we are growing on the customer base, and we have deployed a lot of new technology. This is when I was meeting with my great investor, Dr. Patrick Soon-Shiong, and always hearing his vision. He always wanted to create the NORAD of healthcare. We listen how many people are doing mission control throughout the country. It seems to be the term that everybody likes today, command and control, mission control. And he basically wanted to create the NORAD of healthcare that connects all these mission control centers and now creates that solution that has all the data from the mission control centers with the right augmented AI and machine learning to be able to take that data and provide the right actionable insights. So I was talking to him, And that's when he said, Alan, our vision is very complementary. We talk about the narrative of healthcare. You have created at Airstrip a very strong platform that we call the intelligent clinical operating environment. Mm-hmm. You guys created a command and control, a clinical communication layer, an analytics layer for visualization and providing actionable insights. This is the time where we need to look at the bigger picture, Alan, and use the technology from Airstrip as the Trojan horse, as the foundation for a new entity. But in this new entity, we need to look at human signal processing. We need to look at the signal that comes from the medical devices, from body sensors, from many other data sources. We have to start partnering with acute care clinicians, doctors, and clinical extenders. We need to look at the network infrastructure where we can have cloud, we can have fiber optic, a layer one, a cabling infrastructure, where we can actually start providing high velocity and secure data archiving and analyzing data in motion. So that's when we started talking about Adjuvare. And the name he came up with this idea, and he said, well, what is that drives us? And we said, I always said, it's to help others in moments in need. It's to help out. Right. And if you look at the definition, I looked at it the other day on the web, and it says, to help out is to share the burden of something with another person. So this is where you partner with your providers to figure out risk sharing models where you can actually improve the model of healthcare. And then Patrick said, the right name is Adjuvare, which means to help out.
Nice. I like that.
So that's how all this came about. And we said, this is going to be powered by the Airstrip technology, by the Airstrip customers, by the Airstrip team. So this is where it all comes together. And now we're starting to add other partners into this ecosystem.
So I want to dive more into the company, but before we go there, let's talk about what does this really mean for Airstrip customers? It sounds like this is an extension of the platform, so you'll continue to support customers similar to how you've done for years. Is that the right thing? But then they'll just have new opportunities for an expanded control center and things like that. Is that what Airstrip customers should read about this?
Yeah, so I think it's very important when you are in like Airstrip, a technology company, you have to realize that when you're moving to a next level where you're combining advanced technology with virtual clinical, acute care clinical services, you have to realize you cannot do this alone. They are the ones that raised the flag to us saying, this is what we need. And they didn't say we need primary care. They said we need acute care staffing services. So I realized that with Patrick, actually, that we had to bring the customers as the partners to help us to figure out exactly what are the immediate objectives they need to accomplish and what are the immediate resources they need to be able to deal with the issues at hand. And so what happens to our customers? They told us to bring acute care services. Actually, we met groups of, we're actually going to announce some partnerships potentially by JP Morgan at the beginning of January with groups of acute care physicians and clinical extenders that were introduced to us by our customers. These were physicians and extenders that were already providing in-person services to those hospitals that now are reinventing themselves to create a virtual care, acute care, a clinical service model. And it was introduced to us by the customers. So basically, what it means to the customers is that we're listening. And now we are creating an entity where we're going to bring their expertise to really combine services and technology to provide this next generation of virtual acute care.
And is that the approach? I mean, that's what, to me, hearing you talk about Adjuvare, the approach seems to be you have the platform, but you need a lot more devices and connectivity and partnerships that way, so you have all of the data that's needed. I mean, certainly you've done a lot of that already, but just blowing that up, and then also bringing in the person services, which I think that's quite a change, right? I mean, from the technology company that Airstrip is to now, providing kind of this virtual acute care specialty services with the doctors, more similar to like an SOC telemed in the acute care space as well, but with all of the connected devices of the ICU. Is that the right, direction and approach that you're taking now, Adjuvare?
Yeah, so it's yes, the answer is yes, but it's very interesting when the market today talks about providing hospital level care beyond the four walls of the hospital. I hear that the market size, the serviceable addressable market for post-acute care transition it's about $50 billion plus. Total addressable market, $140 billion plus. Home acute care, they're talking about 10.9 billion with a 15 billion total addressable market. Mm-hmm. So the reality is that when I look at that opportunity and I look at the fact that we're all talking about outside of the four walls, but we're still ignoring the needs of the hospital. How is that we want to replicate that outside of the four walls of the hospital with less technology and less clinical staff? And that's all of a sudden is going to be the answer to everything. So yes, what I need to do, John, is first leverage everything we have learned so far with our customers and first create the next generation of virtual acute care inside the four walls of the hospital. And once we have that very well figured out, start replicating that immediately into those two places in the hospital that are the doors to the home, the emergency department and the general wards. Because you come into the hospital through the emergency department, either you get admitted or you go back home. Once you get admitted, you go through the ICU, the OR, telemetry units, step down, general wards, and then you go home. So you have to use the ER and the general ward as the laboratory environments to bring the right technology to go into the home. And this is where you need to start bringing virtual acute care services and concentrate on that subset of patients that were acute or semi-acute. So you can start monitoring them in the ER and in the general wards. Since the general wards don't usually have patient monitors connected on a network, this is where you need to start bringing precision body sensors. This is where you bring a patch that gives you biomarkers such as heart rate, respiratory rate, skin temperature, cough frequency, gait, body position, eventually waveforms, and SpO2. So you can monitor the patient there using a virtual group of clinicians. And when they go home, it's the same technology and the same group of doctors that are going to continue monitoring, John. Imagine if you already went through the hospital, you had a heart attack, you were in the cath lab, ICU, telemetry, general ward, and I'm telling you right now, I'm going to put a patch on you the next 3-4 days that you are at the general ward, and there is a group of doctors and nurses that are watching you on a real-time basis, near real-time basis. So then, once I send you home, you're going to walk away with this sensor and the doctors are going to follow you. It's the same team that is going to follow you. So for the next 30 days, I'm going to have those people looking at you to make sure that you are evolving in the right, with the expected outcomes that we want in your specific condition. That didn't happen even before COVID. So what happens is, that is the best way to move outside of the hospital, is to really improve the hospital level of care for acute and semi-acute care, acute patients. improve it there, create a new model, follow the patient home. Don't think that you're going to send them with a scale, a blood pressure cuff, a pulse oximeter, and say, good luck. And by the way, somebody's going to drive and make sure that they talk to you once a day. That is not the way to do home care.
Yeah. Well, I mean, I was going to say, we started to see some of that, like you described, like, here's a pulse ox, let's stay in touch, because they didn't have beds for them to be able to monitor them. So there was a need, there was a demand for this, going back to the staff augmentation idea as well, and the beds. But I find it fascinating. I mean, in many ways, you're almost turning that bed in the hospital, in every bed in the hospital, into a kind of ICU monitored bed. Is that how you would look at this? And then obviously you described connecting that to home beyond just, the visit to the hospital.
So John, that's why I always love talking to you, because you get it. The only change to what you said is that I would like to convert every one of those beds to an ICU telemetry, a telemetry bed. So there is a difference between intensive care and intermediate care.
Uh-huh.
And yes, intermediate care, otherwise called telemetry or step down, you're still on a monitor, getting the data on a near real-time basis. But you're not monitored like you're in the ICU with a one-to-one ratio for the nurses and a central station that is watching you every moment, and the nurses come every 15 minutes, and they do all the charting.
If they're lucky. You're being generous right now. Yes, we know how staffing works with nurses, but yeah.
So now, in essence, what we're building here, and that's the key, the question you asked is the key, is we need to make sure that that general ward becomes a telemetry unit. That bed has to become a telemetry bed, but now it has a sensor. And when you go outside of the home, of the hospital, and you go into the home, if you were an acute or semi-acute patient, that home becomes a telemetry bed, because you want to, if you're looking at length of stay reduction and reduction of readmissions, when people say those two things, they're talking about home to hospital. But you need to look at this in today's world differently. And let me explain to you how that is. You're coming into the hospital in an ambulance. Let's just look at the future in Q1 of next year. Mm-hmm. Let me give you a picture of the future in Q1 of next year.
Okay.
A patient has chest pain. They get picked up by the ambulance. They're on a defibrillator that can communicate or not to the cardiology system in the hospital. But if it doesn't, you put a sensor that is collecting the data from that patient and is sending that data at, let's say, 200 hertz a second mm-hmm. through the cell phone to the cardiology system, to the ER. Well, all of a sudden now I can have an ER doctor looking at your data before you arrive in the hospital. That didn't happen before. Mm-hmm. I can read the alert from that device and say, this person is having this condition. So now, even if that condition is an arrhythmia, like AFib or anything else, ST elevation, that could be a heart attack. Then you walk into the ER, and now that ER is flooded with people because of a pandemic that could be aggravated with a hurricane, like it happened in New Orleans. Mm-hmm. So now that ER, the length of stay in that place could be an entire day. There could be beds in the hallways where they need to have actually ICU doctors monitoring those beds because they don't have room in the ICU, and you're in the ER. So now all of a sudden length of stay becomes an issue of the ER. Now you have to make sure that you accelerate the time to intervention, because the more you accelerate the time intervention, you're healthier just by accelerating, fixing the problem that you that you are coming to the hospital to be able to take care of. Once you get transferred to the ICU, it's the same thing. We need to reduce the length of stay in the ICU. Well, it all happens by doing a good job in the ER. You know, the sooner I work on you, less you're going to be in the ICU, because potentially if you had a heart attack, I cleared the artery faster, and now you have a better ejection fraction. Not only you're going to be less in the ICU, but you're going to have a better quality of life moving forward. Then you move into telemetry. If you were there for 4 days, now I can actually reduce the length of stay in the telemetry unit, but also reduce the readmission into the ICU. If I monitor you more, if I send you to the general ward with a patch, with a sensor, and that becomes a telemetry unit, I move you faster through the system. Less time in the ICU, less time in telemetry, less time in general ward, and now I can send you home with the same level of telemetry virtual acute care, but not just with the doctors in the hospital, but doctors and nurses and physician assistants and telemetry technicians that could be watching you remotely. This is a system that will work, but you have to look at the enterprise, and you have to fix it from the hospital side. That's why I like what CMS is doing here. Hospital level care beyond the hospital walls. You have to be prescribed a sensor in the hospital visit for you to be able to qualify for that reimbursement. So that means it's not just anybody on a sensor out there. You have to start with the hospital and with some level of care moving throughout the hospital.
I think the problem, everyone loves the idea of more data about the patients and having it available, all that telemetry data from every bed. I imagine many listening are thinking, what do I do with all that data? It's kind of like everyone said, hey, if I update all my Fitbit tracking data, the primary care doctor says, what do I do with that data, right? It's a similar effect. I mean, the data is obviously much higher quality and more medically relevant than your Fitbit data, right? But I think what's interesting, though, if I hear it right, and I think you mentioned it briefly, was applying a smart dashboard. So maybe you could talk about that. Like, how are you making these dashboards smarter? Because if I'm a hospital healthcare organization, acute care doctor, I'm like, I have enough to deal with. I don't need another dashboard with more data than I have now, right? So how do we make that smart? But then also, I think maybe is that why you added on the augmented services, right? The other ICU care doctors to address this, scale problem, right? Because you're taking all this telemetry data and saying, let's, overwhelm the hospital with data in some ways, right? So how do I scale to the challenge of processing that data effectively?
Yes. Well, thank you. This is a great question. So, of course, we have to start for the general audience by saying you have to take big data into smart data. Mm-hmm. So of course, you have to start with the big data, and then you have to realize, what is that I need to do with this data to make it smart? So that's the key of what we have built over the last decade. It's really looking at what are the data sources I need to tap into to solve a particular clinical workflow. Every area of the care system or a disease or a condition has clinical workflows that follow that patient as they come through the system and they go into the home. So the first thing you need to do is, of course, collect that data. And that was already a challenge for the last 10 years, but I think it's improving, John. We can, if we were here in a bar, I would just toast to you for the fact that the data is finally open.
Are the devices there? I mean, the devices are there to give you the data that you need?
Yeah, so I get to that in 2 seconds. The first thing you need to do is collect the data, process that data, and of course, standardize it and all that. But you need to start taking that data that is now normalized, structurally mapped, and standardized, and you need to find ways to extract knowledge from that data. This is level one of big data to smart data.
Mm-hmm.
And what you do is you start creating clinical domain watch list where you block the things you don't need specific for a cardiac patient. You look just at the lab results that are good for, that are important or relevant for a cardiac patient. If they happen to be cardiac with diabetes, then you look at lab results that are specific to those conditions. And you start extracting the knowledge from that data. That's the layer one of a platform. That's the knowledge domain. And then once you have that, you need to start extracting wisdom from that knowledge, because that's what you need to deliver to that group of doctors or nurses inside the hospital, or the ones that are looking at the data remotely. In other words, you take all the patients, you disease classify them, you risk stratify them, and now you start displaying that the data that is relevant for those patients on a near real-time basis, so the extenders and the doctors that are looking at that, either from the hospital or remote, now they're seeing all their patients throughout multiple hospitals, disease classified, risk stratified, and now you touch into that. Imagine this is what we call our care traffic control.
Mm-hmm.
Instead of an air traffic control, you're looking at that care traffic control tower. It is a virtual dashboard, a virtual central station where you're seeing the list of all your patients. If you're a hospitalist, that you're looking at those patients from multiple hospitals, multiple units, but now they're all disease classified, risk stratified. You can touch one of these patients on the screen. You see the lab results, what medications they're on. You can actually see the real-time waveform and see if there is any alert event. You can take a snippet of that waveform, send it to the EHR, and now you document the whole process. And of course, what we are moving into, working with a very important academic medical center, it's the next generation of waveform analysis, cardiac waveform analysis. How can I start doing early detection of arrhythmias and eventually prediction of arrhythmias or any other condition? To answer your question about the devices, you will be surprised that, of course, we don't have to worry about the inpatient side, because the big companies, the medical device companies, they have it. They have all this data coming to you, and some of them better than others. And I know them very well, so I know which ones I like to work closer to, and our customers see that in the market. And as you move outside of the hospital, I want to be at Adjuvare, the trusted partner that realizes which are the sensors per clinical condition that are going to give me the data that I need, the biomarkers that I need to be able to follow that patient home. And today, we're very happy with a handful of sensors that are giving me ECG, the heart rate. They're giving us the skin temperature, the respiratory rate. They're giving us cough frequency. They're giving us a gait, a body position. So already we're getting all those. We see the filings for some of those, FDA filings for some of those sensors for SpO2, waveforms. Those are my core capabilities. Once I get that data, you know, John, this has been our world for the last 11 years.
Yep.
So finally, all those, I call them precision body sensors, you're going to see in the next 6 months, they're going to send all that data that I need to really leverage all the tools that Airstrip provides to us. And now within Adjuvare, when I take that human signal, we will be able to bring it across groups of doctors that are acute care doctors and clinical extenders. We're going to disease, classify per condition, and re-stratify those patients. So now they can sit down in front of a virtual care traffic control and navigate this beautiful new world that is all happening now.
You know, it was interesting when we first started talking about doing this interview. You referenced an article I wrote that I said, you know, remote patient monitoring is kind of being developed as we take off the plane, you know, as the plane takes off, and that we're building it on the fly. You know, and in our discussion, I kind of thought about it more. I said, no, maybe that's not quite the right analogy. Maybe the right analogy is, you know, we're not the Wright brothers airplane, right? But we're maybe not the F-16 either, right? Or F-18, I guess is the latest one. You know, like, so where do you kind of see us in that progression of developing this technology to turn that data into wisdom, right? And to have the data that we need and having it developed. Are we literally building this as we take off, or how do you view kind of where we're at in the value that can be created from this right now?
So I love that article that you wrote and the fact that you use that analogy, because the first thing that came to my mind was, well, he talks about devices slash platform analytics and communication tools. Well, the devices are just data sources. So let's just consider the platform then. And platform for me is extracting knowledge from the data. And when you talk about analytics, I was like, well, that's for me, extracting wisdom from the knowledge.
Yeah.
And you talked about communication, and that for me is the delivery engine. And it's what in Patrick, Dr. Soon-Shiong's vision was always about delivery. I mean, knowledge domain, wisdom domain, and delivery domain. Mm-hmm. So then when I saw that article, I was like, well, really what happens is there is a plane that took off from an airstrip. And that plane was a stealth fighter and took off and landed on an airstrip. And now that we landed, this is Adjuvare. And now this is what we are going to do. We are bringing all kinds of tools that we want to bring to healthcare, but we have been stealth. But this is powered by airstrip. And it's a very good analogy. And we landed and nobody knew that we just landed. And the mission, the first mission was completed. Now the next mission cannot be accomplished just by airstrip by itself. It has to be done with an ecosystem of technology and virtual acute care services.
Well, what a way to finish. I love the airstrip comparison. It seemed apt and appropriate. And I love the vision of, you know, virtual acute care. And you know, you've always, you know, enlightened me on access to the telemetry and how hard that is, one, and two, how important it is. So Alan, this is great. Congratulations on the new company, Adjuvare. No doubt we'll be watching it and watching Airstrip's evolution. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Alan.
Thank you so much.